clavicle here. So this is your cervical spine from here to here. Now, when we talk about that, when it comes to accessing these parts of the spine, you can access the bottom two and the middle one through a small incision way down low, and you can access the ones up high through another small incision up high. Now, when somebody has multiple herniated discs in their neck and they're all causing equivocal symptoms and problems and they need all four taken care of at once, that's something I do in a hospital, but that requires a really big incision. And it's a big surgery to recover from, and it's not very friendly to have done with a personal injury case because it has to be done in a hospital and it's very expensive, XYZ. When it comes to doing surgeries, you can access the bottom two through a small incision and the top two through another small incision. That being said, the ones at the top of your neck at C3-4, you do have a disc herniation at C3-4, but it's not really pinching your nerves or your spinal cord. It might be pinching the little nerve on the side, but that nerve only controls pain in the neck and towards the back of the head. Okay, so the ones down low at C5-6 and C6-7, those are pressing on your spinal cord and your nerves, and those are giving you everything, you name it, neck pain, headaches, pain into your shoulders, and numbness in your hands. So those two are clearly the most obvious culprits here. Now, the ones up higher, if we do surgery on the two bad ones down low, you might have some still pain from neck pain up top. But the goal of surgery would be to take the pressure off of the nerves in your spinal cord so that you don't continue to get worse, because this is what happens. Kind of have pain, then you get some numbness, and then as it goes on, you don't really notice, and your brain just adapts to it, and you start to lose function. And that's really the goal of surgery, is to take the pressure off of the nerves. And if we could get your pain controlled, that's just icing on the cake. I'm certain that we'll be able to get your pain better after surgery. The question is, how much of it? Do I expect that 100% of your pain is going to be gone? No, because you have more problems in your neck. The other question becomes, do we do a 2-level fusion or a 1-level fusion with a 1-level artificial disc? I know previously we had spoken about this. Since you're otherwise young and active, you want to be active. The surgery is the same. This is a lumbar model, but it's the same concept in the neck. You go in through the front, you take the herniation out, the disc out, and you replace it with something so that it has something to stand on. The old tried and true method is what's called a fusion. You put a spacer between them and you lock it in place.
I'm making faces. Yeah, I don't want to do a fusion because I know that puts extra pressure on the vertebrae above and below.
Yeah. Sometimes it does. The jury's kind of out on that. It makes sense that it does do that it accelerates things, but there's other people that have it done and they go for decades and the rest of their lives without needing anything done. So yes, you can make an argument for both cases, and that's what I'm trying to say here is that's the tried and true way. You lock it into place. You don't have to worry about it dinging and giving you pain. The other option is the artificial disc. Now, theoretically, you have increased, not theoretically, you do have increased range of motion. So what that means is if there's any sort of residual compression of the nerve, like out laterally, that we can't get through direct, there's two major arteries that run in your neck. So when you're looking at it, you do direct decompression off the spinal cord, and then you have to kind of pluck some of the stuff out what you can't see. And you can only go so far to do that before you start getting dangerous and start risking, life-threatening hemorrhage. So when you do an indirect decompression, you put the spacer in there and it lifts it up. And oftentimes, if there's any little bit left in there, that's enough to give it space. Now, that happens whether you do an artificial disc or a fusion. It's still a spacer, which increases that space. With an artificial disc, you put the spacer in there and you lift it up, but there's still a lot of motion. So you're sacrificing a little bit of pain for increased range of motion. Does that make sense? So I have seen multiple times where people expect all their neck pain to be gone, or sometimes they get some pinching after an artificial disc, and that's because you still have motion in there and you're going to have these issues. So, I tend to like to be upfront. If it's the artificial disc that we want and you don't want to have, that being said, you can still have adjacent level issues with an artificial disc. It's just less likely. I'll just stop there and see if you have any questions.
I don't know. I feel like I'm sweating. The thought.
We know what we need. We know you need at least 2 levels of your discs in your neck fixed. It's a matter of what we put back in there. At C6-7, way down low, that's attached to your ribs. So that doesn't move anyway. So there we can do a fusion because you're not going to have an issue down lower. It's when you do a fusion in the middle of the neck where there's all this motion that you start to have problems. So what we could do is do the fusion down low and do the artificial disc at the level above where you do have motion if you want, but you can have time to think about it between now and the time we get you to surgery. Do I want the artificial disc there or do I want the fusion? And again, there's surgeons that they say no artificial discs at all because of this, because they don't like, expectations after surgery. People come back and still having some pinching, but again, you've taken the pressure off of the nerves and you've prevented that further nerve damage. So it's more of an annoying pain after surgery. And I have seen people go back in and take those artificial discs out and replace it with a fusion because the person didn't want to continue having those nagging pains in their neck. Does that make sense?
All right. Well, that's good to understand, I think. Yeah.
So, the option is we could try the artificial disc up front, and a vast majority of the people that I do this on, they do excellent. And I've seen it only happen once that somebody wanted to go back and have it taken out to have the fusion done.
Wow.
In thousands of surgeries. But it is a possibility, and, there's a reason that the FDA has guidelines. People under the age of 50 shouldn't have artificial discs, all this XYZ, and, I've just come around full circle several times. If you want an artificial disc, you shouldn't be cut off because of your age. But there's certain criteria. For example, you start to develop bone spurs after a certain age, and because of that, you're going to have this little micro motion that give you pinches, and subsequently you'll have suboptimal results. So, as long as you're informed and you make an informed decision, we can do either one for you.
All right. That's a lot to consider.
Yeah, it is. The surgery itself, we go through the front, 2 levels. It'll take about an hour. You go home the same day. You're sore at the back base of the neck. That's from the stretching of the joints. That can last anywhere from a couple of days to several weeks to a couple of months. Generally, people need about 4 weeks off from work, depending on what you do. I've done this on people, and they feel so great they want to go back to work at the end of the first week. I wouldn't recommend that because your muscles and joints are going to need some time to adjust. People tend to overdo it when they feel too good initially. But in general, I recommend if you could take 6 weeks off, take 6 weeks off, and we can send you back earlier depending on how well you're doing.
Okay. All right. Well, that's a big consideration then.
Right.
Crap. Yeah.
And you will have a collar on, but that you could take off as necessary, as needed. But in general, the recovery process takes about 6 weeks.
All right. And is there physical therapy involved? And
if necessary.
Okay.
But not before 6 weeks, because you're healing in that entire 6-week period.
All right.
So take some time, think about it. Just let us know. We've got a plan for you.
All right. All right. Well, thank you.
You're welcome. Now, it looks like you have an allergy to perfume. You have throat swelling.
Yep. And
you get hives from a leaf.
I do.
Okay.
And I can't take morphine. It makes my head want to explode.
Okay. Now, how about all the other symptoms we discussed before about are you still having those concussive symptoms? What are you left with? Are you still having any headaches, difficulty concentrating?
I am, both. And honestly, my brain health has really got me stressed out. And so the idea of even being anesthetized for 10 seconds kind of freaks me out because my memory stinks. I'm struggling, and I'm the kind that I've got a lot of things going on.
Right. Yeah, well, I wouldn't worry too much about that. We monitor you with neurophysiologic monitoring to make sure your brain's getting.
Oh, it's not. I trust you guys in that regard. Do you know where I work?
Are you? I remember you told me one time.
I'm the director of admissions for the largest assisted living facility in Hillsborough County. So I got 400 grandparents, average age 80 years old. So I see them when they come back from surgeries and stuff. I've been doing it for, there in that building 11 years. So I see confusion. I see early onset dementia, stuff from surgeries. It's not pretty.
Yeah, it's scary stuff. That's why we try to keep the surgery as quick as possible.
Thank you.
On my end.
Yeah. So anyway, so that's a consideration. And then,
absolutely.
And the head trauma.
If you're just having some neck pain from those 2 levels above, just leave them. They might be just like that forever, but definitely C5-6 and C6-7 are pressing on your spinal cord and your nerves, and you're just going to continue to lose function if you don't get them taken care of.
Yeah. All right.
All right. So just let us know what you decide. We're always here. We'll schedule around your availability.
I appreciate it. Thank you.
All right.
Okay.
You're welcome. Bye-bye.
Bye.